Ladies and gentlemen, we will have discussion later after the second speaker. You may write it down in the Q&A column. So now let's go to our second speaker. Very often, following a laminectomy, patient recover without any complications, but sometimes cause a condition where the patient still suffer from persistent pain in the back following the surgery. For the second speaker, we have Dr. Altan from Turkey that will talk about interventional pain management in post-laminectomy syndrome. Dr. Altan Shahin, please start.
Hello, I would like to thank you, Mr. Chairman, and my dear big brother Sustilo for inviting me to this very prestigious Congress held every year. And I will talk about the interventional pain management in post-laminectomy pain, and which was before it was called failed back surgery syndrome. I have no conflict of interest, and my plan will be, I will talk about first about the general terms of post-laminectomy syndrome, then the clinical picture, and then I will talk about the management of the post-laminectomy syndrome. So, as I told you, it was previously called failed back surgery syndrome, but our surgeon friends are hesitating to use that term because they never fail, and that's why now we call it post-laminectomy syndrome. Well, spine surgery in the recent years is increasing, and there has been an upward trend in total number of fusion, especially in fusion cases in the world. As you can see in this Reisner study, between 1998 and 2008, and then another study, 1998 and 2014, there has been an enormous increase in the incidence of prevalence of spine surgery, spinal fusion. And the elective lumbar fusion increased about 62% between years between 2004 and 2015. And when we look for the hospital costs, they increased 177% during these 12 years. And it exceeds $10 billion only in 2015. And per admission, it costs about $50,000 US. And if we come to the definition of failed back surgery syndrome by the ISP, lumbar spinal pain of unknown origin, either persisting despite surgical intervention or appearing after surgical intervention for spinal pain originally in the same topographical location. The etiology of failed back surgery syndrome might be preoperative, which are the patient factors, intraoperative factors, and postoperative factors. Let's talk now about the preoperative factors. One of them is anxiety, depression, or other psychiatric conditions of the patient. Obesity is a factor, and smoking is also a factor. Presence of litigation or workers' compensation claims, and physical or radiological findings such as stenosis, fibrosis, and disc herniation are preoperative patient factors. And strongest association is the psychosocial factors of the patient, and choice of an inappropriate surgical candidate or surgical approach may be a preoperative factor. And the patients who undergo multiple prior back surgeries have higher chance of developing post-laminectomy syndrome and a lower chance of having a successful pain relief with the surgery. The intraoperative risks are operating at the wrong vertebral level. Well, usually the surgeons can miss the the lumbarization or sacralization and operate the wrong level. And operating at a single level, while there are several other levels are ill too. An improper technique during surgery is a risk factor. And of course, operative complications like hematoma and infection are the things, the complications that may cause postoperative pain, post-laminectomy pain. And when we look at the postoperative factors, after the surgery, the spinal stenosis might increase, spinal instability might come back again. Epidural fibrosis is very important and can be treated with several interventions, and disruption of adjacent discs, and of course, recurrence of the disease are postoperative factors. When we look at the epidemiology, chronic low back pain is experienced by the people in 51 to 84% throughout their lifetime. And 10 to 40% of patients having surgery have failed back surgery syndrome. And this might go up to 46% in lumbar fusion. However, even in microdiscectomy, there's a risk of 20-25% of developing post-laminectomy syndrome. When we look at the pathophysiology, lateral stenosis of the foramina may be a cause, painful disc degeneration, disc herniation, neuropathic pain, pseudoarthrosis, as I told, epidural fibrosis, and increased spinal instability due to discectomy or laminectomy, and the redistribution of load to the adjacent disc tissue, which is called adjacent level disease. Well, in history taking, we must know the character and the location of the patient's pain compared to the pre-surgical pain. And if there's a lack of immediate pain relief, we must suspect operation at the wrong level. And if there's a new onset of pain, it might be a surgically induced nerve damage or hematoma or whatsoever. And if there's a low back pain, the facet joint arthropathy might be one of the causes. Of course, sacroiliac joint issues and myofascial etiology must be thought too in history. The red flags to interact are one of them is the Cauda-Equina syndrome, is seen with saddle anesthesia and bowel and bladder incontinence. An infection is very important. Fever, chills, and weight loss might be the symptoms of it, and malignancy is another red flag. Sorry. In physical examination, if the patient has spinal stenosis, it's usually exacerbated when the patient is extended spinal extension and relieved by flexion. So, and disc herniation, recurrent disc herniation may present with a positive sign of straight leg raise. In diagnosis, we use some tools like X-ray. We can see the vertebral and sacroiliac defects, misalignments, and spondylolisthesis with X-ray. And we can see adjacent segment degeneration in X-ray, and loss of lordosis might be observed. In MRI, especially with contrast media, epidural fibrosis can be shown, and also disc herniation, recurrent disc herniation can be shown with MRI. And if the patient has an instrument, there might be artifacts in the MRI, so CT myelogram is a good choice to perform in these patients. Of course, to look for infection, search for infection, sedimentation rate, and C-reactive protein is a very useful tools. Of course, there are some interventional diagnostic tools like diagnostic nerve blocks. If you are thinking about facet joint arthropathy, dual medial branch blocks 2 times must be performed, might show us that the problem is in the facet joints. If the patient, we perform lateral branch blocks or intra-articular sacroiliac injections, we can have clues about sacroiliac joint pain. If we think of a foraminal stenosis, a transforaminal epidural, or a selective single level block might be performed to diagnose which level is problematic. And provocative discography is used to evaluate the discogenic pain. And the management might be, first of all, it might be conservative, like physical therapy is important, developing tolerance, neuroadaptation, conditioning, and some exercises to strengthen the back muscles are of importance. Medications like non-steroidal anti-inflammatory drugs and opioids, anticonvulsants, and antidepressants are important, especially if the patient has a neuropathic pain. Anticonvulsants and antidepressants might be used, but we must be very cautious about using NSAIDs because using in a very prolonged time, we must follow the renal function tests as it makes spasm in the afferent glomerular arteriole in the glomerulus. Cognitive and behavioral therapy is also might be used, and there are also invasive management tools like interventional blocks or radiofrequency or whatsoever, and surgery. The interventional techniques might be medial branch radiofrequency ablation, dorsoroot ganglion pulse radiofrequency, adhesiolysis if there isn't adhesions shown, epidural steroid injections, sacroiliac blocks and denervation, and of course, neuromodulatory interventions like spinal cord stimulation or programmable intrathecal pumps. Surgery, when we talk about surgery, the patient there must be some obvious, clearly identified pathologies for the reoperation. And a reoperation is usually have less outcome, lower outcome, and higher morbidity if there is a reoperation. Bowel and bladder impairment, motor weakness, or neurological deficits. In case of these symptoms, the immediate surgical intervention is mandatory. The interventional techniques that we use in pain practice might be diagnostic, as I've told, and therapeutical. Diagnostic interventions are medial branch blocks, intra-articular facet joint injections, lateral branch blocks or intra-articular SIG injection, and transforaminal epidural and discography. Medial branch blocks are, this is a procedure which an anesthetic is injected to the small nerve, very small nerves called the medial branch nerves. And you see here, the medial branch nerves have one nerve innervates the lower and the equal level facet joints. And intra-articular facet joint injections is, I no longer do this, but it might be done. And you just inject some local anesthetic to the facet joint, inside the facet joint, under fluoroscopy, of course. Lateral branch blocks and intra-articular sacroiliac joint injections are done between the sacroiliac joint and the sacral foramina in S1, S2, and S3, where sacroiliac joint is innervated. Transforaminals, as I've told you, epidurals can be done, and this should be done under fluoroscopy again, and we must see the anterior epidural spread and root spread of the contrast media, and then give the local anesthetic or steroid or whatsoever. Provocative discography mimics the physiologic disc loads and evoke the patient's pain by increasing intradiscal pressure with an injection. And we can also see the different shapes of the disc, pathological shapes of the disc, like cotton ball and irregular fissures and ruptures, even ruptures too. And so if the patient feels pain, so that might be the problematic disc, and this can give us some idea. Therapeutic interventions are medial branch radiofrequency, dorsal root ganglion PRF, adhesiolysis, steroid injections, sacroiliac denervation, and neuromodulation. And medial branch radiofrequency ablation targets we have the target of refractory low back pain. The target is zygoapophyseal joints. And we know that significant pain relief and functional improvement happens after these blocks. But usually when we use radio frequency, we have to wait 2 to 3 weeks to have the clear effects of radio frequency. So if the patient is likely to feel pain during the couple of weeks, these couple of weeks. And the study by Nikolai Bogduk's group revealed that after dual comparative medial branch blocks, 60% of patients had 90% pain relief at 12 months, which is a great result. And 87% experienced at least 60% pain relief. Another study revealed 100% pain relief with dual comparative medial branch blocks, and 53 to 58% of patients experience this complete relief up to 15 months after radiofrequency ablation of the lumbar medial branches. And with a primary outcome of 50% reduction in this study, as you can see, more than 50% reduction was 56% of the patients, 80% reduction 22%, and 100% reduction was 12.9%. And after 24 months, of course, this pain relief has decreased down to 44% pain relief. Radiculopathy or radicular pain after lumbar surgery is reported as an etiology of failed back surgery in approximately 10% of the patients. And pulse radio frequency of the dorsal root ganglion can effectively manage the lumbosacral radiculopathic pain in patients. So this is a study with electrophysiologically shown radiculopathy, neuropathy, or no normal subjects have been performed dorsal root ganglion pulse radio frequency in this study, and you see there is a considerable
decrease in the pain scores, numeric rating scale, and Oswestry disability index in all three groups of patients. And this is a prospective non-randomized study. They studied 56 patients. Either one group had transforaminal epidural steroid, another group additionally had a DRG pulse radio frequency. And in all groups, both groups, there have been a considerable significant pain relief after the treatment. And when we look at the sciatica bothersomeness index, the PRF group, pulse radio frequency group, had better results. This study shows that early clinical outcome after revision operation or radiofrequency treatment. And they studied 70 patients. This is a very recent study. And the results are quite similar in these patients into back pain, leg pain, Oswestry score, and short form 36 score. And of course, the revision operation had a lot of complications like infection and additional surgeries, and neurologic deficits was the same in both groups. And epidural injections might be done with steroids or hyaluronidase to treat the epidural fibrosis. This study shows that 60 patients with documented fibrosis in fewer than 3 nerve roots, and they gave hyaluronidase to one group, methylprednisolone to the other, and both to the other group. And the analgesia at 1 month was okay, but the effects reduced 3 to 6 months follow-ups, and there is no statistical differences between the 3 groups. And this is the study by Manchikanti. It's a randomized control study. Interesting. One group received lidocaine, the other lidocaine plus steroid, and the primary outcome was 50% improvement. And you see that either the numeric rating scores and Oswestry disability index were similar in both groups. So they conclude that caudal epidural injections work in lower extremity pain in patients with post-lumbar surgery syndrome. Sacroiliac denervation is another issue. As we know, adjacent segment disease is important. If the patient is stabilized, fusion surgery is done in the lumbar area, sacroiliac pain is reported up to 43%, and imaging shows 75% of sacroiliac degeneration. And if spinal fixation is done to the sacroiliac joint, so the next joint is the hip, so hip osteoarthrosis increases. So how do we denervate the sacroiliac joint? With conventional radiofrequency, bipolar radiofrequency, simplicity multipolar probe, cooled radiofrequency, or endoscopic radiofrequency. This is the conventional radiofrequency lesioning, just one monopolar electrode. We perform it, and this is bipolar. So with bipolar radiofrequency ablation, we increase the lesion size, and so it is more better than the monopolar. This is the multipolar probe, Simplicity 3, which makes 2 bipolar lesions and 3 monopolar lesions, and it is placed between sacroiliac joint and sacral foramina. And this is a very effective and very good thing. And an S1 facet joint must be added to this procedure. And this is cooled radio frequency. This is another technique, and there are 3 points in first and second sacral foramina, and 2 points at the third sacral foramina. And these are this is quite a long procedure, but it is very effective. And this is this endoscopic sacroiliac joint denervation introduced by So Choi. And this you can do this denervation under visualization here. So this study had 121 patients, and they reviewed 2 different ablation techniques, monopolar and simplicity. And you see multipolar simplicity has better outcomes in both pain scores and quality of life scores. And this study shows cooled radio frequency is a safe and effective method in patients sacroiliac problems. And this study just recently published has 23 patients and 79 for endoscopic radio frequency treatment, and 79% of the patients had good outcome and long outcome. Epidural adhesiolysis can be done with RAX procedure or epiduroscopically. And this is about the percutaneous adhesiolysis, the RAX procedure, and it might be used after conservative management is done. And this is another study that says that RAX procedure is a well-tolerated, safe, and effective treatment. And this one is endoscopic adhesiolysis and percutaneous adhesiolysis are compared, and they conclude that percutaneous adhesiolysis has level 1, and epiduroscopy has level 2 to 3 evidence level, and both might be used for low back and lower extremity pain. And this is a very recent study by Gedoke, and they showed a significant reduction in pain scores and Oswestry Disability Index. And there are these studies that show that there's reduced need for spinal cord stimulation when we perform epiduroscopic lesions of adhesions under vision, and the total cost is at least more than 10 times. And this is another study that shows that. And spinal cord stimulations is the final thing to do in these patients. And how it works, it decreases ascending nociception, increases descending inhibition, and modulates the pain perception. And this study by Richard North, who is a surgeon, that it is better to have spinal cord stimulation rather than reoperating the patients. And this is another comparison with conventional medical management and spinal cord stimulation. So spinal cord stimulation is better than that. There are different kinds of spinal cord stimulations, high frequency and low frequency, traditional and burst suppression, and they are all good. And high frequency stimulation is studied in a Senza RCT, and we see the back pain is better controlled in this high frequency treatment, and this is the 24 months follow-up, and it's still high frequency is better in these patients. And spinal cord stimulation with additional peripheral nerve field stimulation might be used, and with these in this study, they say. This is an interesting patient of mine, 49-year-old female, and there's a very bizarre, you see there are 12 levels of instrumentation, and there was a really hard fibrosis. So we opened this fibrosis with the catheter that we use in epiduroscopy, a radio frequency catheter, open the space for the electrode and put the electrode through that space. It was the toughest case I ever had in spinal cord stimulation. So in summary, indications of lumbar surgery must be considered carefully before the operation, as there is a high risk of post-laminectomy syndrome. More screws means more pain, and the cause of post-laminectomy syndrome is complex, where the management must be tailored according to the possible etiology. There are plenty of treatment options. However, when there's plenty of options, there is uncertainty. And avoiding surgery when possible seems to be the best option. So thank you very much. Greetings from Turkey, and I hope we meet face-to-face again in Indonesia, or I would in Turkey too. Thank you very much.
Thank you very much, Dr. Altan Zain. Alhamdulillah Rabbil Alamin. We still have some time for the discussion. Let me raise the question for Dr. Imani. Dr. Imani, there's a question here regarding the back pain associated with the old fracture. As we know, that is very common right now. Is there any algorithm or how to treat or how to diagnose those kind of old fractured vertebrae? Probably you have some explanation for this.
Thank you very much. Usually, for vertebral fractures, we perform the best result during 6 months after the fracture. And if more than 6 months, there's not good candidate. But if the patient remains her or his back pain without radiculopathy, we can take an MRI. And if there remains the edema, it's maybe the augmentation may be useful. But if the vertebral fracture is cold or remains more than 1 year, or if there is no pain, this is not good candidate for this procedure.
So related to your explanation is that if the patient has already had a fracture more than 6 months, it's not a good candidate for augmentation, right? I'm just trying to emphasize that. And
yes,
let me bring up another question for you, Dr. Imani. After chyloplasty, do you immediately adjust for pain medication? So probably the questioner is wondering how to treat the patient. Should we taper it off, or should we just aggressively just stop the pain medication afterwards? Please, doctor.
To provide the best result after the augmentation, this is very important that the first after the inclusion exclusion good exclusion criteria, and after that we take a CT scan up to 2 hours after the procedure to watch or if there is any spinal leakage in the canal or not. And after that we can some mild medication, for example, Remsade or acetaminophen, and we can ambulate the patient about 6 or 12 hours after the procedure. Therefore, we don't disconnection or discontinuation of the medication, but this is not need to high analgesic. Usually mild analgesic is enough for this patient.
So probably acetaminophen or some NSAID
Yes.
should be sufficient, right?
Yes.
Okay. Is there any red flags that we should know about this augmentation, doctor? So, meaning to say that it's a big no-no for this patient.
Yes. The most red flag is the pain suffer from radiculopathy if there is the posterior wall of the vertebral body is not intact, or is fracture in the burst fracture or in the cord compression, or these are not candidated for the augmentation. Only the fracture, including compression fracture, usually about 1/2 of the height is reduced. No compression, no radiculopathy, no infection, no burst fracture. These are good candidates for scheduled augmentation.
Okay, thank you for your answer. Now let's relate your explanation, Dr. Imani, with Professor Altan. There's a question here. Will there be any chance that post-laminectomy syndrome will happen after chyloplasty? So I don't know about this, but is there any relation between those post-laminectomy and chyloplasty procedure? Please, Professor Altan.
Well, I'm not aware of such a thing. Of course, there are some complications, and post-laminectomy syndrome happens after surgery, and there might be some complications are included in the etiology of this. So there are some complications of kyphoplasty and vertebroplasty, as Professor Imani said. And the leakage is very important, but what can be done is really challenging in these kind of issues. And actually, it is not a post-laminectomy syndrome or failed back surgery syndrome. This is not a surgery. This is that is an intervention. So, but every intervention has its own complications and own favors.
Yes. Okay. Thank you for that. There's a question here regarding the usage of pregabalin before the treatment of post-laminectomy syndrome. Is there any advantages if we give pregabalin beforehand?
Well, as I told you, as I told in my lecture, the conservative treatment should be done properly. So one of the drugs used in conservative treatment is pregabalin. If the patient has a neuropathic pain, so we can check it with DN4 or Lance scale. And if the patient has neuropathic pain, of course, pregabalin is the first-line treatment of neuropathic pain. However, if it doesn't work or it cannot relieve pain enough, so we go to the interventions.
Okay, doctor. For both of you, there's this question: is that how long should we wait for the conservative therapy, or for example, physiotherapy or any other therapy before we do any intervention? Please, probably Dr. Imani can start.
Usually 2 or 3 months we the conservative treatment for the patient, and if there is full physiotherapy, medication, bed rest, and ergonomy of the patient is not a good response to medication and physiotherapy, usually conservative during 2 or 3 months. And if this is not appropriate response, after that they're scheduled for appropriate intervention.
Okay, so if the patient already underwent physiotherapy for 2 or 3 months or any other medication, then probably this is the best time for kyphoscolpy, right, doctor? Okay, so what about you, Professor Sahin? Should we wait or should we just go directly to intervention?
Well, what I think is, well, give it a try to the conservative methods, but if they don't work after, I don't wait 3-4 months if the patient still experiencing pain, suffering pain. So there's no need to suffer pain. So if there are some effective treatments, we should immediately do it. I do wait some for example, couple of weeks, or a month, but if there is no pain relief after these, and especially if the patient, if under medical therapy, there are side effects of these drugs, and which can be excruciating to these patients, I do interventions.
Okay, doctor. There's this question. I think this is for Dr. Sahin. There are this kind of anatomical distortion after they perform laminectomy, right? So probably the epidural space is altered, or any other condition that can make the anatomy much more different than the normal person. If they want, or if we want to inject steroids, will it disperse, or will it reach the height that we want after the procedure of laminectomy?
Of course, this is a problem. Very good question. Thank you very much. And because there is epidural fibrosis, and this fibrotic tissue may attach to the nerve root, sometimes you cannot reach the target. So especially in these patients, I prefer radiofrequency, and the radiofrequency must be done awake, in awake patient with mild sedation and analgesia, and the nerves must be found, the sensorial nerves must be found. I know there are some other techniques with using motor sensation and finding a multifidus twitch and then burn there. This is not the case in these patients. You must find the sensorial nerve, even if you're performing facet radiofrequency or DRG radiofrequency, you must find the nerve. And this is a problem in these kind of patients. And in order to open this fibrosis, hyaluronic acid and mechanical adhesiolysis is important treatment options.
Okay, thank you very much for all the answers. To all the speakers, let me wrap up everything that we've talked about this afternoon. So for all the doctors here, we need to consider for pain management, especially related to the vertebrae. There are some previous, before we do interventional, sometimes we need to pull the brake and reevaluate the patient. Just take your time. Probably physiotherapy or any medication that can relieve the patient, it will help. But after sometimes you need to decide whether we need to do interventional pain management or not. For a vertebral body fractured, there are lots of technique right now that was mentioned a while ago by Professor Imani. There are lots of choices about that. And for post-laminectomy pain, I like what you said, Professor. Less screw, less pain. I will remember that for the rest of my life, I think. Okay, thank you very much for all the speakers. Let me close this session by a prayer. Subhanakallahumma wa bihamdika, ashhadu an la ilaha illa anta, astaghfiruka wa atubu ilaik. Let's pray for the peace of the world. Thank you very much. Doctors.
Thank you very much.